Hello, good evening. Hello. Hello.
Hello, sir. Good evening, sir.
Yeah, good evening.
Yes, sir. Yes, sir. Good evening, sir.
Good
Yes, sir. Nice to have you, sir.
Yeah, thank you very much.
Yes, sir.
Do you have another person in class?
Yes, we are almost
I think
15, I think,
I
sir.
think everybody just joined and left. It's okay. Actually, I want to finish the course today. My own part, I want to finish it all today.
All right, sir.
The same way I have difficulty in sharing on this Zoom. I was told it's going to use PDF. So
Hello, sir. Is the slide showing, sir? Is the screen showing, sir?
no, it's not showing yet.
You can send it to me.
Okay, sir. Okay, let me send it to Dr. Akpan. I will send it to him now, sir. Let me do that, sir.
I'm online here.
Níta bá ti ṣe láàrin ìbá wọn ni wọn sí online mi bá dẹ̀ wá ti pọ̀ ọ̀gá lánàá gan. Okay, ó bẹ́ẹ̀ tàbí ẹ̀yẹn kọ́ gàba wá ṣe àrò.
Dr. Akpan, good evening, sir.
Good evening, Mr. Adebayo. How was the day?
Okay, how was your Sunday?
Fine, thank you. And yours?
It's beautiful.
Sure.
Thank you.
All right, sir. Mo ti send it, sir.
Okay, let me just.
Okay, it's showing now. Thank you. So let's start. Next slide. Let's go to the next slide. Hello.
Hello, sir.
Yeah. Dr. Akpan, can we go to the next slide?
So sorry, I think it's because of the PDF, but I think we are on now.
Yeah. Okay. Okay.
Yeah. Yes.
Yeah. But actually, it's not this. I sent two slides. Okay. Okay. Let me do this first. Do the other. So the first slide is actually, this slide is titled red blood cell membrane structure. Just a minute. Okay. 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 Now, good evening once again. Sorry for the hiccups. So we'll be talking about the RBC membrane structure in relation to blood group antigen location. So RBC membrane display blood group antigen. As we all know, that's where the antigen attached to on the blood cells, on the red blood cells, I mean. And is positioned on glycolipid and glycoprotein, which projects towards the lipid layer. It's just telling us the structure, general structure of the red blood cell membrane. I mean, what this slide is saying, general structure. Just introducing us to the general structure of the red blood cell membrane. ABO antigen appear as carbohydrate groups on the surface of oligosaccharide, while protein antigen, like that of Duffy or Rhesus, they wound round the membrane many times, and they are bearing the antigen region, which is exposed outside of the cell. Next slide, please.
Mr. Adeyemi,
Yep.
please, do you have the PowerPoint, the normal PowerPoint, not the PDF converted? Because this is
Yes.
giving me a little issue. Please, can you just send that one to me? That's straight. Please.
Okay.
Please. Yeah.
Okay, let me go to it.
Thank you.
Okay. I've sent it, Dr. Hello, Dr. Pan, have you seen it?
Yes, I've seen it. I've seen it.
Okay.
I've seen it. Just a second. I'll be live now.
No problem.
Yeah. Okay. Let me know.
Okay.
Yeah, we've seen it.
Yeah, can we go on now?
Please, let's go on. Let me just
Yeah.
read this
So
way.
let's do
Okay, next slide.
the
Okay,
next slide. Move on
okay,
to the next, please.
okay.
All right. No, there's a slide before this. Slide number 3.
The overview.
Okay. Overview. Yeah.
Yes.
Yeah. The RBC membrane is dynamic, deformable, lipid protein bilayer. It's a combination of both lipid and protein. That's what it's telling us. And that forms the biconcave shape that the red blood cell have. Deformability and selective permeability because of the layer the lipid protein layer gives the red blood cell membrane is biconcave shape, is deformability and selective permeability. The function of RBC membrane is to provide mechanical stability, ions transportation, to present antigen and interact with the protein in the plasma. Next slide, please. So the membrane, just tabulate it for easy because it's too wordy. So I just tabulate it. Basically, the membrane is made up of lipid, proteins, and carbohydrates. And the percentage of lipid is 40, that of protein is 42, and carbohydrate has the lowest concentration. Their function is as stated on the slide. And let's go to the next slide so that we don't. Now, the structural component is a very important slide for us. Structural component of the membrane. The bilayer, lipid bilayer, like we said, contains lipid, protein, and carbohydrates. So the lipid bilayer, it is symmetrical. The outer leaflet is enriched with glycolipids. That's why it is glycolipid. I mean, that's why it contains lipid and glycolipid means contains lipid and carbohydrates, so to speak, and glycoprotein, exposing antigen. Its fluidity is modulated by cholesterol. That is, they use cholesterol for it to be able to flow. Now, the integral protein, what this means is what the protein that it really contains. So it contains glycophorins, glycophorin A, glycophorin B, band 3, and the resource complex. Those are the protein integral because some blood group are carbohydrate based, while some are protein based. For instance, Duffy and resource are protein based, while ABO are carbohydrate based. So all these things has their own importance. So the integral protein for the membrane is as listed on the slide. Now, the peripheral protein, different between this one is internal. I mean, the integral is the inner one, while the peripheral is the one that is on the surface. And that is this spectrin, the acrin. For us, of course, we are all in hematology. When you talk about elliptocytosis and spherocytosis, these two proteins are significant. I think one is for elliptocytes, while the other is for spherocytes. I'm not sure which of the two, but these two proteins contain on the membrane, dictate the shape of the red cells. So that is why we have to know this slide. The next slide, please. Blood group antigen localization. So where the blood group are located, the system and where they are located on the membrane. For instance, ABO, the carrier is glycophorin A. Glycophorin A, molecular type is glycoprotein, and it's localized. It stays on the extracellular carbohydrate. Like I told you, ABO is carbohydrate based. If you look at Duffy, you see it's protein based, integral protein. It's extracellular. So it's just telling us different blood groups and what they are made up of and where they are located. Next slide. the clinical relevance rather. The membrane defects affect antigen expression. For instance, like I told you, on the other slide, the two protein, it's talking about hereditary spherocytosis, weak D variant. So is the membrane, if there's a defect on the membrane, maybe if a particular protein or a particular carbohydrate is lacking, I think it's spectrin for spherocytes. If it's lacking on the surface of the red blood cell, then the cell will be spherocytic in nature. And for weak D variant, we all know about DU. There is not enough DU. If the resource is lacking, the protein carrying resource is lacking on the membrane, the reaction with anti-D will be very weak. So that is what this is saying. Precise localization help in blood group serology, donor selection, and safe transfusion practice, because they are going to help us to detect the blood group of a particular sample. And the last slide is just the quiz, because I don't want us to go without practicing. So when you look at the slides, like this one, like the first question, say highlight the structural component of the red blood cell membrane and the expression of. We'll be discussing that after we have gone through this, and maybe during our revision, we'll discuss what exactly we are supposed to say for this particular question. I think that's the end of that topic for BGS. Let's move to the last. Dr. Pan.
Yes, I'm with you. Have you sent it?
I actually converted it to PDF because the Zoom stuff was telling me I can't load PowerPoint.
Okay, send it like that. We'll see how we can manage.
Okay. Sent.
Okay, I've seen it. I've seen it. Okay. Just a second.
So,
Okay. All right.
yeah.
Okay, we can go on. Can you see the slide?
Yes, I can. It's going now.
Okay.
Thank you.
Yes.
So this topic is about WHO standard in blood cell. That is what WHO expects us to be doing in our laboratory. And this is what people come to see when they want to give us ISO or any other certification for that matter. Next slide, please. So WHO standard in BGS ensure accurate testing, safe transfusion, and effective management, quality management for that matter. It also protects donor, recipient, and the med lab scientists and other personnel working in the lab. Strict adherence to this standard is crucial for minimizing transfusion-related risks and improving health for end user. Next slide, please. So the requirements, WHO quality system is one of the requirements. So these are the documents that are expected of us to be kept in the lab, the SOPs and other documentation on our equipment, on the personnel training, on the control, both internal and external. Okay, next one is even internal and external quality control. We have to do this, especially the external control is supposed to be done minimally once in a year. Internal control, of course, we have to do that more often. Then equipment standardization is talking about calibration of our equipment, the centrifuge, and other machines or equipment that we use should be properly calibrated, properly controlled, and should be retired as at when due. So the next slide is talking about biosafety. That is another thing that is expected of us to be done by WHO. We talk about the PPE, which are the gloves, lab coat, protected eye protection, proper waste disposal and chaff management, use of biosafety cabinet for high-risk specimens like those of us. That is TB, but I think there are some other things that we can do. Then annual biosafety and infection control training to update our knowledge. Next slide. Another requirement is the standardization of our reagents and anti-sera. WHO mandate that all reagents used in BGS must be, one, they must have quality requirements that can be traceable to the WHO reference standard. They must be highly potent, specific, and specific. They should be free from contamination and must be well labeled with lot number and expiry date. The storage requirements for our anti-sera must be well maintained at 2 to 8 degrees. Anti-seras are not meant to be frozen. So there should be revalidation after transporting our reagent and anti-sera. Revalidation after transportation or temperature excursion. Next slide. What are the requirements that is expected, WHO expected us to meet for ABO grouping? Most of us will do only forward grouping, but that is not what is expected of us. Both forward and reverse grouping must perform at all times on patients. As a matter of fact, it helps us to detect hemolysin when you are doing blood for dangerous group O. So forward grouping and reverse grouping is a must for us if we are following the WHO standard. The forward grouping and reverse grouping must agree with each other. If not, we should resolve the discrepancies before moving forward. Now, for resource D typing, the use of monoclonal IgM anti-D for resource D, that is our usual typing. But for week D typing, week D is the same thing as DU anyway. It is mandatory for all donors. It is optional for recipients, depend on the policy of the institution in which we work. For typing with week D, you are not supposed to use the regular anti-D. You're supposed to use incomplete anti-D, and that is IgG anti-D anyway. So, and then you go ahead and confirm. You finish the grouping with AHG. That is AI, like we are doing indirect mistakes. That's what we are doing when we are trying to detect the issue. Next slide, please. The next standard expected was WHO standard for antibody screening and identification. Screening must be done using two-set screening panel. Screening is required for all transfusion patients, antenatal women, donors, depending on the policy. For the reason for screening recipients is that you want to know if they have any antibody before transfusion. Apart from saving you that you are the one that put the antibody there, it helps in selection of blood when doing cross-matching so that you know which blood to cross-match for patients. Then when you screen and you find antibody, the next thing is for us to identify the antibody. An extended phenotype panel must be used, and clinically significant antibody like G, K, and E must be confirmed. There was one of my lectures that someone was saying most of the time they will have transfusion reaction, and when they cross match, there's nothing there. One of the reasons is this now. One, the recipient may have antibody already, all these clinically significant antibodies, which we have not screened for in the lab. So that could be the cause. Then again, maybe there's like we are giving O to another group, maybe there's hemolysin, high titer hemolysin that may cause that transfusion. Let's slide this. So we'll be talking about WHO standard for cross-matching or compatibility test. One, immediate spin cross-match is allowed only when antibody screening is negative. That is after doing antibody screening for the recipient. You can do immediate spin cross-match. Immediate spin cross-match, by the way, is the rapid cross-match. Just add cell to serum, and you check for antibody. You check for agglutination. If there's no agglutination, you can safely say the blood is okay for transfusion. But that cannot be done unless you have performed antibody screening on the recipient, and the antibody screening was found to be negative anyway. Then you have to be sure that the patient has no history of antibody. Then another thing that's expected of us is that AIT cross-match is required when antibody are detected or suspected. You cannot do rapid cross-match for for any recipient that produces antibody or that has an history of antibody production, or you suspect that they might have antibody. You cannot do rapid screening because all these other blood groups might have, they might have antibody for all these other small blood, which might cause transfusion reaction, either acute or delayed transfusion reaction. Patient has a pass. Of course, you have to do AIT for patients who has passive of antibody production. Now, compatibility rule is that no incompatible reaction can be ignored. That is, no matter how little or how small reaction is, cannot be ignored. Then, number two is you must also always ensure that ABO and resource compatibility pass. That is, ABO and resource must be compatible for every unit before we give out the blood. That's the issue. The next slide, please. The next one is WHO requirements for donor blood testing. All donors must undergo one APO and resource type. Then they must also undergo antibody screening to detect if they have any hidden antibody. They must also undergo, according to WHO, the TTIs, screening for TTI infection. And it's not that they will come today and whenever they come again, you skip. You have to do it every time, every single time they come forward. Then what must be labeled on donor's bag is the blood group, the results, donor ID, collection, and expiry dates. Next slide. Next slide. Now, how to interpret according to WHO standard. For instance, in my facility, even not until recently, we used to put dash, 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 where there's no agglutination. But according to WHO, this is how we grade. If there is no reaction, it's 0. If the reaction is not that visible, 1. 2, according to the strength or the avidity of what you are seeing. That's how you grade. You don't put minus or plus or NR, non-reactive, or R, reactive, for any serological test, apart from the TTIs, the blood bank. All discrepancies must be resolved before issuance of results. Use decision algorithm to determine the next step. For instance, if you have any discrepancy, what do you want to do next? Depending on the algorithm of your institution, whether you are repeating the test or you are using another technique or you are sending the test outside to another center to validate. Next slide, please. What are the requirements for personnel training? Staff must be trained, they must be assessed and certified as competent yearly, as there should be a competency test for all staffs, and there should be continuous training on serological technique, biosafety, quality management, and equipment operation. These are the things that is expected of us by WHO. Next slide, please. So you should be able to trace a unit of blood according to WHO, the record keeping and traceability. It is very essential for us to be able to trace a unit of blood from when the donor drops it till when it is received or discard, depending on what happened after donation, whether it is positive for TTI or expired or what have you. From the beginning to end, the blood should be able to have trace. So in doing that, we have to have appropriate records, which we keep test results for all the tests performed on the blood rather, quality documentation, that is quality control performed on all the tests, equipment log, incident report, if there's any incident, transfusion reaction as well. And all these records are expected to be kept for 5 years or more, depending on the national regulation of where the institution is located. Next slide. I think that's the end of this.
That should be the end of the slides.
Yeah, that is the end. So that's the end of the class, actually. I'm supposed to have a quiz, a slide for quiz at the end of this, but I omitted, I forgot to add it. So I will send it to the class for. That's what they sent to us. That's all about our course for BGS, and thank God for starting with us and for taking us this far. I want to ask if you have any question or contribution before we move forward. Concerning the 2 lectures that was given, if you have any question? All right. In the absence of none, I want to thank everyone. You have a question. Okay, I'm with you.
Sir, I have questions, sir.
Okay, I'm listening.
On TTI screening.
Okay.
As far as Oyo State is concerned, apart from UCH, we have National Blood Transfusion Commission, and we have CMDC.
Okay.
I don't think there's any government established screening center for blood apart from this again. And we have a society, Hematology and Blood Transfusion Scientists Society of Nigeria. We are in Oyo State too, but I don't know what is actually happening. I think we can rise up to this challenge. I don't know if the society maybe you can see Oyo State government that only even it's not everybody that has access to National Blood Transfusion Commission to just say my patient or my relative need blood for transfusion. And CMDC is not enough to cater for the whole hospitals in Oyo State. So as hematologists, what can we do about this? Because we know that this rapid test we're using for screening of the TTIs cannot detect the window period. What of those people outside Ibadan? People are receiving blood every day, but it is only this rapid method that other hospitals are using, other hospital laboratories are using, except those in Ibadan. So I used to feel late that, okay, what of if any one of us need blood too, and it happens that one is in a place outside Ibadan, which type of blood, especially when it is in case of emergency? So it is my concern that we have to do something about it. And it's not just one person, it's not what just one person can do. But we're supposed to have to have one voice as hematologists. Because if we don't have one voice, so who will help us to say it out? That this is the ideal thing. Because some people that are not hematologists, they will just say, oh, should be hematology. As if we are just playing hematology.
Okay. Yeah, I share your concern and I feel your pains, truly. Actually, the National Blood Transfusion Agency in Ibadan is a federal setup. It's a federal establishment. It is something that's supposed to be replicated by all states, and by extension, those ones in the state are supposed to be the center where all the local government will bring their units, they will be screened and sent back to them. But unfortunately, because of the country that we are in, policies are made, but they are not followed as they're supposed to be. So it's a big challenge because even WHO, they don't allow any center to screen for TTI using rapid screen because it has been confirmed that rapid strips are not good enough for screening for TTIs. So what I don't know, but I believe that with all of us speaking in one voice, like you say, if we can raise a policy paper and maybe see who is who. Now we even have one of us in the house now that we can say, okay, we have someone that we can just attach to who can help us. Maybe if we start from Oyo State. For instance, in Ogun State where I am, there used to be a National Blood Transfusion Service or yes, in Abeokuta. But the thing has been scrapped because they said there's no fund. So it's only the teaching hospitals like the FMC, the Olabisi Onabanjo University Teaching Hospital that have a ELISA machine that can screen. Most private hospitals and other general hospitals, I think they use rapid screen too, which is bad. So we, like you said, we have to come together, maybe find a way of making a policy paper, not only as Association of Hematology and Blood Transfusion Science of Nigeria, scientists of Nigeria, but also as Medical Laboratory Science of Nigeria, Association of Medical Laboratory Science. Maybe if we go together and raise our voice, we can make a mark. That's what I can say about that.
Sir, please, I have a question also.
All right.
I was trying to raise my hand, yeah.
I'm raising my hand, though. I'm raising my hand.
Please, sir,
I've been raising my
I
hand,
raised my
though.
hand before.
Sorry,
Okay.
Ms. Akibile, you will speak after her.
Okay, sir, thank you, sir. Please, I just wanted to, a kind of clarification on this donor screening. You know, you mentioned WHO standard for blood grouping, but then for donor, you are saying, you know, for patient, you are just saying forward and then reverse. Then under the donor, you were saying antibody screening. So my question is that antibody screening, are we going to be doing the reverse grouping for it on that antibody screening for donors?
No, reverse grouping will not detect antibody. Reverse grouping is going to collaborate what the forward grouping does. If you do forward grouping, either using the tube or the tie method, you are reacting antiserum with the blood cell. But if you do antibody screening, you'll be using AHG
Yes,
to look for any hidden antibody in the donor. So they are doing two different things. You understand? So if we have any other blood groups in donors now, that one will not be picked while doing cross-matching if they are flow titer. But if you do antibody screening for donor, you will be able to detect that the donor has the antibody. So on the bag, you are not going to use the bag for whole blood transfusion. You have to remove the plasma because that is where the antibody resides. You remove the plasma and you use ordinary cell, for the patient, and you have to mark that blood too, that it contains so antibody, so that when given to recipient, it will be recipient that does not have the corresponding antigen that will receive that type of blood. Then you can use that type of blood also for fractionalization. If at all you want to use the plasma, you have to fractionalize the plasma, maybe to produce coagulation factor or to produce albumin or other things apart from using it for FFP. I don't know if you understand what I'm saying. Ms. Onuka, are you there or you've gone?
Thank you, sir. Yes, sir. Yes, I'm there.
Okay. So
thank you, sir.
You're welcome. So let's talk to Ms. Let's speak with Ms. Akinbule, if I get it right, I hope.
Thank you very much, sir. Thank you.
You're welcome.
I just want to shed some light because I'm privy to some information based on the issues Mrs. Adidapo just raised. Because firstly, I've worked at CMGC where she mentioned for screening, and of course, currently I'm the chairman of the Association for your state. So I just want to inform us or intimate us with some informations. Actually, the state of things is really actually is very bad, with the state of screening center. Even the CMDC that she just mentioned is not, because it's even the only center screening for the whole of the states, even for private. And because of this, hello?
Hello,
Am I being heard? Okay. And because of this,
yes.
the low standard and all of this, it has actually degraded to the level that one of the families or relatives of the Commissioner for Health fell into this trap too, that they couldn't get a good blood and all. It was a very, very big issue. And that has translated, or this has made the government, the governor, to really look into the state of things at that blood bank, that is the CMDC, and now to really make it a standard place for screening, because they got there and they were able to see that we don't even have a blood bank, as in a functional blood bank. We don't have lights. We use rapid screening kits and all of that, of which even before then we have been raising memos and we've been doing a series of meetings. But now they have taken action, and we believe at least maybe max by the beginning of next year, that is max, things would really change. And after this, of course, replication will.
Hello. Mr. Kimbile, I can't hear you. Can you hear me?
It may be a network, sir.
Thank you. Am I being heard?
We missed you at a point, maybe because of network. But we appreciate the information you just gave to us, and we hope that the government will follow through with their promises. However, as a medlab scientist, I think if we can try and refuse some task, maybe we can get some things done. For instance, the rapidly screened blood should not even be entertained at all, especially in that place called as big as yours. I don't know, Mr. Akimbile has gone. But however,
Yeah, I'm
thank you
here.
very much.
Yeah,
Okay,
I'm here,
yeah,
sir.
all right, all
Well,
right.
okay, you said
I know it's a big challenge
in
for
fact, if we
us.
stop it, even right now that we are doing rapid screening, they still bring blood that we screen rapidly and are positive. So we feel even if we stop it, then the whole thing will just, a lot of directors have been there that couldn't. There was no way. We're just trying to balance it and just patch up in the absence, because it will just worsen the whole case. Because now we still screen with rapid, and we get to see so many positive blood for hepatitis, for HIV, even with rapid screening. So if we stop it, they can do anything at their hand, and that would be very, very disastrous. But this is actually being looked at. Their ISN is coming. They are really going to, the same stand, or not that they want to. They are already doing it. The plan is on ground. They have started making the place conducive for that. Everything is ongoing actually, and we are
Okay,
so glad, and we believe is within a short while things will.
it's okay. Thank God. At least somebody has smile to the place. Thank you very much for the information. So, do we have any other contribution or question or addition? All right. So, in the absence of none, I want to thank you once again for being here with me. And during the course of the week, I'm going to send some questions. They are not going to be so difficult, just something for us to practice or to answer rather for our continuous assessment, so that we can have something down for continuous assessment. Also, I want the class rep to send me the list of attendance, so that we should have documentation that people come to class, and based on that, we are giving the mark that is meant for attendance. I think it's 10 mark according to the school policy. It's supposed to be 10 mark for attendance. Then continuous assessment too, we have its own mark. I will send question for continuous assessment on or before Friday to the class rep, and where the assignment will be submitted to by God's grace. So thank you very much. Let's bring the class to an end if there is no other thing to discuss.
Thank you, Mr. Adeyemi.
Thank you, sir. Dr. Akpano, you have one information for us?
I think we have come to the end of our lectures as much as possible. The other ones that I did was assignments, continuous assessment on some one or two subjects, topics. So that will be submitted later in the month, or according to the classroom, maybe towards the end of the year. I was thinking that maybe before the exam, but so I think we should just continue to look at our projects and our seminars. We have time now, and go through what we have been taught. If you have any issue, we are both available. Please just get across to us through the classroom. You can ask for our numbers. And then for the project, I think we should continue to check and see what we can submit now, so that by January, we should be done with our project. And then we'll be waiting for the exams for first semester, and then move swiftly into the second semester too, which we'll do in the speed of light too. But thank you very much, everyone.
Okay. Good night, everyone. Thank you.
Thank you, sir.
Good
Thank you, Master.